Yes, guys, good afternoon. So, we'll be continuing a small part of the lower limb session, and with that, we'll be done with the lower limb, and then we'll move to the next part of anatomy. Okay, so if you see this next picture, okay, what they are trying to show you is the sciatic nerve and the course of the sciatic nerve and the branches of the sciatic nerve. Okay, so the main part of sciatic nerve, okay, it is okay, sciatic nerve. If you see, it is formed from lumbosacral plexus. It is formed from lumbosacral plexus. Okay, it is formed from lumbosacral plexus, and it has got root value of L4, L5, S1, S2, and S3. Okay, and this sciatic nerve, it has got two components in it. It has got two components in it. One is called as a tibial component. One is called as a tibial component. Okay, another one is called as the common peroneal component. Another one is called as a common peroneal component. Another one is called as a common peroneal component. Another one is called as a common peroneal component. Okay, so tibial component. Another one is called as common peroneal component. Clear? So this tibial component supplies most of the muscles in the hamstring region. You all know that. So all the muscles, okay, all the muscles in the hamstring region are supplied by the tibial component. Okay, except one muscle, okay, which is supplied by the common peroneal component, that is the short head of biceps femoris. Short head of biceps femoris. Okay, this is the supply of the sciatic nerve in the thigh region. Okay, see, when you see this sciatic nerve, when the sciatic nerve reaches the superior angle of the popliteal fossa, you can see the popliteal fossa here. You can see the popliteal fossa here. This is the superior angle of the popliteal fossa. When it reaches the superior angle of the popliteal fossa, okay, when it reaches the superior angle of the popliteal fossa, it divides into two components. Okay, popliteal fossa, it divides into two. Okay, it divides into the two proper nerves, that is the tibial nerve and the common peroneal nerve. That is the tibial nerve and the common peroneal nerve. And when you see the course of the sciatic nerve comes out of the greater sciatic foramen. So you see the muscle here. This is piriformis muscle, and it comes out of the greater sciatic foramen below the piriformis muscle. So sciatic nerve is coming below the piriformis muscle, and sometimes the nerve can come through the piriformis muscle also. It can come through the piriformis muscle also, and sometimes the nerve can get compressed due to piriformis, resulting in piriformis syndrome, where the nerve can get compressed due to the piriformis muscle. Yesterday we saw a syndrome called as pronator teres syndrome. Okay, this is piriformis syndrome. There is a syndrome called as pronator teres syndrome. Can anybody tell me what is called as the pronator teres syndrome? What is a nerve that is affected in pronator teres syndrome? Very good, Prithviraj, very good. It is median nerve. Okay, so with this background, we'll move to the next part of the foot and ankle. See, we will discuss this deltoid ligament in detail when we come to the ankle joint. Okay, so don't worry about this picture now. Okay, we'll discuss about that in a short while. We'll go to the posterior compartment of the leg here. Okay, we'll go to after the popliteal fossa, we are going to the posterior compartment of the leg. So when you see the posterior compartment of the leg, okay, again you got a lot of muscles here. To understand the muscles or to study the muscles, we'll just make a simple diagram, cross sectional diagram, so that will be very easy for you to understand the muscles. Okay, so if you draw a cross section of the leg, okay, so the leg has got the following bones in it. Okay, so it has got a tibia. Okay, so it has got the tibia on one side, and it has got the fibula on the other side. So let us draw the fibula tibia here. Okay, so this is tibia, okay, so I'll just draw it in a different color. So tibia is here. Okay, so tibia is here. Okay, and you got on the other side a small bone called as fibula. Okay, and these two bones are connected by means of a membrane called as the interosseous membrane. They are connected by a membrane called as interosseous membrane. Okay, if you see the tibia has got medial surface, okay, it has got an anterolateral surface, okay, it has got an anterolateral surface, and has got an posterior surface. Tibia is like a triangle shaped bone. Tibia is like a triangle shaped bone, okay. So if you see the surface, this surface is called as the medial surface of the tibia. This is called as the medial surface of the tibia, okay. This is called as the medial surface of the tibia, and this surface is called as the anterolateral. This is called as the anterolateral surface. This is called as the anterolateral surface of the tibia. This is called as the anterolateral surface of the tibia. And what is this surface? This surface is called as the posterior surface of the tibia. This is called as the posterior surface of the tibia, okay. This is called as the posterior surface of the tibia. So when you look into the fibula again has got a similar kind of surfaces. So what you see here is the anterior surface. This is the anterior surface of the fibula. This is the lateral surface of the fibula. This is the lateral surface of the fibula, and this is the posterior surface of the fibula. This is the posterior surface of the fibula, okay. So you divide the leg into several compartments. You divide the leg into several compartments by means of the intermuscular septums, and the intermuscular septums which are seen here are, there is a septum which is here, and there is a septum which is here, okay. So these are certain septums. We'll just draw it in a different color so that you can understand the septums clearly, okay. So what are this, okay. So these are all the septums, okay. These are all the intermuscular septums which are seen here. These are all the intermuscular septums which are seen here, okay. So if you see here, the leg has got 4 compartments, okay. So how many compartments are there in the leg? So the compartments in the leg are, okay, the compartments in the leg are 4 in number, guys, okay. So what are the 4 compartments in the leg? One is called as the anterior compartment of the leg. One is called as the anterior compartment of the leg, okay. The next one is called as the lateral compartment of the leg. Lateral compartment. The third one is the posterior compartment of the leg. And this posterior compartment of the leg is divided into 2. One is called as a superficial component or superficial compartment. Another one is called as a deep compartment. The anterior compartment of the leg is also called as a extensor compartment, okay. It is also called as the extensor compartment of the ankle. And the lateral compartment is the everter component, okay. It is the everter compartment. And the posterior compartment is the flexor compartment. It is the flexor compartment of the ankle. So if you take the leg has got 3 compartments: anterior compartment, lateral compartment, and the posterior compartment, okay. So we'll just see what are the muscles in this area, and where do this muscle arises from, and what is their function, okay. So if you see these muscles, there is a muscle which arises from the anterolateral surface of the tibia and from the interosseous membrane. The muscle which arises from the anterolateral surface of the tibia, okay, and from the interosseous membrane, this muscle is called as a tibialis anterior muscle. What is this muscle, guys? So we are just talking about the muscles of the anterior compartment of the leg, okay. Okay, so anterior compartment muscles. So one muscle is called as the tibialis anterior muscle, okay. And you can see where the muscle is arising. It is arising from the anterolateral surface of the tibia, and it is also arising from the interosseous membrane, okay. It is arising from the interosseous membrane. It gets inserted sorry guys, it gets inserted into the base of first metatarsal and into the medial cuneiform, okay. So it gets inserted into the base of the first metatarsal and into the medial cuneiform. This is where the tibialis anterior muscle gets inserted into. The tibialis anterior muscle is supplied by the nerve supply of the tibialis anterior muscle is by the deep peroneal nerve, and the action of the tibialis anterior, okay, the action of the tibialis anterior is by okay, is by it causes mainly the inversion. It causes mainly the inversion of foot. It causes mainly inversion of foot. It also helps in dorsiflexion of the foot. It also helps in dorsiflexion of the foot, or dorsiflexion of the ankle is caused by the tibialis anterior muscle. So we are discussing about the anterior compartment muscles. We are discussing about the anterior compartment muscles. We are discussing about the anterior compartment muscles. So the first and foremost muscle is tibialis anterior. The origin we have seen, it is arising from the anterolateral surface of the tibia and from the interosseous membrane, and then it gets inserted into the base of the first metatarsal and the medial cuneiform bone. Okay, it causes inversion of the foot. Okay, it is an inverter of the foot. Okay, so what is called as an inversion of the foot, guys? Yes, anybody can, what do you think about inversion of the foot? Say just when you stand and when you take your medial border of the foot, when you take, okay, when you take, say let us consider this is the medial border of the foot. When you take the medial border of the foot away from the ground, this is called as inversion. Or what is called as inversion? When you take the medial border of the foot away from the ground, it is called as inversion. When you take the lateral border of the foot away from the ground, when you take the lateral border of the foot away from the ground, this is called as eversion. So you can do it in your foot and you can see now. So when you lift your medial border of the foot away from the ground, this is called as inversion. When you take the lateral border of the foot away from the ground, this is called as eversion. Okay, so tibialis anterior is an inverter of the foot. It is an inverter of the foot. So the next three muscles are attached to the fibula. Okay, so what are the three muscles that are attached to the fibula? Okay, so the muscles which are attached to the fibula are three here. Okay, and they are, one is extensor digitorum longus, extensor hallucis longus, and the last muscle called as peroneus tertius. Last muscle called as peroneus tertius. All these three muscles are attached to the fibula. They are not attached to the tibia. They are not attached to the tibia. So they don't have their origin from the tibia. They have their origin mainly from the fibula. They have their origin mainly from the fibula. Okay, fine. So this extensor digitorum. Okay, if you see here, yes, the extensor digitorum hallucis muscle. Okay, the extensor digitorum extensor digitorum longus muscle, the extensor digitorum longus muscle. Okay, then the extensor hallucis longus muscle and the peroneus tertius muscle, and the peroneus tertius muscle, they all causes dorsiflexion. They all causes dorsiflexion of the ankle. They all causes dorsiflexion of the ankle. There is no doubt in it. They all causes dorsiflexion of the ankle. Extensor digitorum longus, in addition to that, extensor digitorum longus in addition to that causes extension of the great toe, extension of the great toe. Okay, and the extensor hallucis longus, just a minute guys, just a minute. Okay, so the extensor hallucis longus cause extension of the great toe. Extensor digitorum longus causes extension of the other toes, so they are all primarily extensors, but the main role of these muscles are, along with the extension of the toes, they also cause dorsiflexion of the ankle. And all these muscles, okay, the entire anterior compartment muscles are supplied by a nerve called as, okay, it is supplied by a nerve called as deep peroneal nerve. Okay, it is supplied by a nerve called as deep peroneal nerve. So deep peroneal nerve is the nerve of the anterior compartment. Okay, is the nerve of the anterior compartment. Suppose if deep peroneal nerve is injured, suppose the deep peroneal nerve is injured, what is the action the patient cannot do? The patient cannot do dorsiflexion of the foot. If you see the anterior surface, this is my anterior surface of the foot, and this is the dorsum of the foot. This is called as dorsiflexion. The patient cannot do dorsiflexion of the foot. Now what happens to the foot? The foot goes into this posture. Like the wrist drop. What drop you will have? The patient will develop foot drop in this. So the take home message is, when deep peroneal nerve is injured, it results in a drop called as foot drop. So please remember this guys. So the anterior compartment muscles are four: tibialis anterior, extensor digitorum longus, extensor hallucis longus, and peroneus tertius. though they causes extension of the toes, they also have got an important function, that is dorsiflexion of the ankle. When the deep peroneal nerve gets injured, the dorsiflexion of the ankle cannot be done. This is called as foot drop. We have discussed in the morning again. When the patient has got foot drop, the patient will have an high stepping gait. The patient will have an high stepping gait. Okay, the patient will have an high stepping gait. Okay, this is what we saw in the morning also. Okay, so this is about the anterior compartment muscles. Now coming to the posterior compartment muscles, as we have discussed, okay, just now, the posterior compartment is divided into two. Okay, it has got a superficial and a deep compartment. So if you see here, there are two compartments here. One is called as the superficial compartment. Okay, another one is called as the deep compartment. Now what are the muscles which are present in the superficial compartment? So you got 4 muscles in the superficial compartment. One is the 2 heads of gastrocnemius. Okay, so 2 heads, the medial head and the lateral head. And you have got a big muscle here, that is the soleus muscle, and below the lateral head of gastrocnemius runs then another muscle called as the plantaris muscle. So you got a plantaris muscle also here. You got a plantaris muscle also here. So we'll just write down here what are the 4 muscles in this region. So you can see the 4 muscles in this region. So this is the superficial compartment. Okay, this is the superficial compartment. And you got the gastrocnemius, which is cut here. You got 2 heads of gastrocnemius. One is called as the medial head, and another one is called as the lateral head of gastrocnemius. Another one is called as the lateral head of gastrocnemius. And you can also very well see below the lateral head of gastrocnemius, you can also see the plantaris muscle. You can also see the plantaris muscle, and you can see the soleus muscle taking origin from the soleal line. So this is the soleus muscle. Okay, and if you see all these muscles, okay, all these muscles joins to form a tendon. Okay, this tendon is called as Achilles tendon. So what is this tendon called as? This tendon is called as Achilles tendon. This tendon is called as Achilles tendon, guys. Okay, very very important tendon. This is the thickest tendon in the body. Okay, Achilles tendon. Okay, if you take Achilles tendon here, so we'll just write here. Okay, Achilles tendon. Achilles tendon is the thickest tendon in the body. It is the thickest tendon in the body. Okay, it is the thickest tendon in the body. Okay, what does Achilles tendon do? Okay, Achilles tendon helps in plantar flexion of the ankle. Okay, helps in plantar flexion of the ankle. Okay, helps in plantar flexion of the ankle. Okay, so what is plantar flexion of the ankle? When you try to stand on your toes, when you try to stand on your toes, when you try to stand on the tip of your toes, your ankle automatically goes in for plantar flexion. This plantar flexion is produced by the triceps surae. What is triceps surae? Okay, so what is triceps surae, guys? Yes, triceps surae is nothing but the fusion of gastrocnemius and the soleus muscle. The soleus muscle and the gastrocnemius muscle, they together called as triceps surae. They are together called as triceps surae. They form a tendon called as Achilles tendon. Achilles tendon is the thickest tendon of the body. It causes plantar flexion of the ankle many times in sports, and sometimes when there is an injury in the ankle region, Achilles tendon can get cut. Achilles tendon can get cut. Okay, so there is an important test to find out the Achilles tendon injury. Okay, so that test is called as Thompson test. That test is called as what? Thompson test. So please remember, guys, Thompson test, very very important. Okay, so Thompson test is a test which is used to check Achilles rupture. Okay, it is used to check the Achilles rupture. It is used to check the Achilles rupture. Okay, fine. So if there is a Thompson's test, if there is a Thompson's test, there is a test called as Thomas test. There is a test called as Thomas test. Can anybody tell me what is called as a Thomas test? What is called as a Thomas test? To which for which condition they do Thomas test? To find out which condition they do Thomas test. Very good, Vinitha, very good. Okay, so to find out the flexion, fixed flexion deformity of the hip, to check the fixed flexion deformity of the hip, they do this test called as the very good Charu and Anashwara. Yeah, you guys are reading very well, guys. Yeah, so Thompson's test is a test used to check the Achilles tendon rupture, whereas Thomas test is a test which is used to check or used to look into the fixed flexion deformity of the hip region, fixed flexion deformity of the hip region. Very good. Okay, so this is about the superficial compartment. Okay, and what is happening in the deep compartment? If you see the deep compartment, the deep compartment has got the following muscles. The muscles in the deep compartment are, okay, so you have an bone here, tibia, okay, and you have the interosseous membrane and the fibula here. If you see here, okay, so there is a muscle which takes origin from the posterior surface of tibia, interosseous membrane, and from the posterior part of the fibula also. So this muscle is a wide muscle which takes origin from both the bones and also from the interosseous membrane. Okay, so this muscle which takes origin from the tibia, posterior surface of tibia, from the interosseous membrane, and from the fibula. Okay, so this muscle is called as tibialis posterior muscle. So what is this muscle, guys? This muscle is called as tibialis posterior muscle. A small word about tibialis posterior muscle. Okay, so where we will write here, we don't have much gap here, so I'll try to contain myself here. So tibialis posterior muscle, guys. Tibialis posterior muscle is a muscle which gets origin from the tibia, fibula, and from the interosseous membrane. It gets inserted into, where does it get inserted? It gets inserted into all the tarsal bones. It gets inserted into all the tarsal bones. Okay, it gets inserted into all the tarsal bones except in one bone it does not get inserted. Can anybody tell me what is the bone that does not receive the insertion of tibialis posterior? Anybody, guys? Yes, it is the talus bone. Okay, it is the talus bone. Talus bone does not receive the insertion of tibialis posterior. And also remember, guys, talus is one bone which does not receive insertion of any muscle. No muscles are inserted into the talus bone. Okay, talus bone is devoid of any muscular attachment. So this is an important point. So tibialis anterior, all the tarsal bones receives the insertion of tibialis posterior except talus. Tibialis posterior also gets inserted into the second, third, and the fourth metatarsal base. It is also inserted into the second, third, and the fourth metatarsal base. So this is about the insertion of tibialis posterior. Tibialis posterior action. Yes, what is the action of tibialis posterior? It is the main inverter of the foot. It is also causing inversion of the foot. So it is the inverter of the foot. So there are two muscles which helps in inversion of the foot. Okay, important, guys, important question. Two muscles which takes place, which causes inversion of the foot. So one muscle is tibialis anterior and the other muscle is tibialis posterior, and the inversion of foot takes place at which joint? It is an important question. Inversion of foot. Okay, inversion of foot takes place at which joint? Anybody, guys? Inversion of foot takes place. This is a very common question. This is a frequently asked question. I think you guys should answer. Yes, so inversion of the foot takes place at a joint in the foot which is called as an subtalar joint. Subtalar joint. Okay, this is called as an subtalar joint. Okay, so guys, please remember there are two muscles which causes inversion of the foot. One is called as tibialis anterior and another one is called as tibialis posterior. So they both cause inversion of the foot, and this inversion of the foot takes place at what? It takes place at the subtalar joint. Oh, so this is about the tibialis posterior muscle. That's the next muscle which is seen in this region, which is arising from the tibia alone. Okay, so you see a muscle here which is arising from the tibia alone. This muscle is called as the flexor digitorum longus. This muscle is called as flexor digitorum longus, and there is a muscle which arises from the fibula here. This muscle is called as flexor hallucis longus. Muscle. Okay, so guys, if you see here, flexor hallucis longus goes to the great toe and the flexor digitorum longus goes to the other four toes. Okay, now if you see the foot arrangement, in the foot arrangement you got the great toe on the medial side and the other toes on the lateral side. So great toe is on the medial side and the other toe is on the lateral side. But if you see the origin of these muscles, flexor hallucis longus is arising from the lateral side and the flexor digitorum longus is arising on the medial side. Okay, so the muscle which has to go to the lateral side is arising from the medial aspect or from the medial bone, that is the tibia, and the muscle which has to go to the medial side, to the great toe, that is flexor hallucis longus, is arising from the lateral side. Okay, so what happens to these muscles? These two muscles cross with one another. Okay, so the crossing of FHL and FDL, flexor digitorum longus and flexor hallucis longus, takes place in the second layer, takes place in the second layer of the sole of the foot, and this crossing point is called as the master knot of Henry. So this is called as master knot of Henry. Okay, so this crossing over is called as the master knot of Henry. Okay, so this is how they cross in the foot. Okay, now all this muscle, when they arise from the posterior aspect of the leg, when they reach the foot, they pass through a retinaculum, and this retinaculum is called as the flexor retinaculum. So what is this retinaculum? So this retinaculum is called as flexor retinaculum of the foot. Okay, the flexor retinaculum of the foot is attached. Okay, the flexor retinaculum of the foot is attached. It is attached above to the medial malleolus. It is attached above to the medial malleolus. And is attached below to the calcaneum, Okay, it is attached below to the calcaneum. Okay, so it is attached below to the calcaneum, and when this retinaculum is there, lot of structure passes beneath it, and you can identify those structures. Okay, so these are the important muscles in this area. Okay, so one is called as tibialis posterior, this is called as tibialis posterior tendon. Okay, this is called as the flexor digitorum longus tendon. Then you get the posterior tibial artery, this is called as posterior tibial artery. Then you also get the nerve, that is a tibial nerve, and the tendon which is going more posteriorly is the flexor hallucis longus tendon. Okay, so we were discussing about the tarsal tunnel, guys. So we are discussing about the tarsal tunnel, how the tarsal tunnel is formed. Okay, it is formed behind a retinaculum called as flexor retinaculum. Okay, it is formed by retinaculum called as flexor retinaculum. See guys, anywhere in the body, if it is in flexor retinaculum of the foot, or extensor retinaculum of the foot, or peroneal retinaculum of the foot, or extensor and flexor retinaculum of the wrist, anywhere if you see the retinaculum, all these retinaculums are modifications of D fascia. They are all modifications of D fascia. Okay, and if you see this flexor retinaculum, and through the flexor retinaculum you have the structures passing through it. Beneath the flexor retinaculum you have the tibialis posterior, which is passing here. Flexor digitorum longus is passing here. Okay, and just behind these tendons, posterior tibial artery and the tibial nerve are running here, and also behind this you have got the flexor hallucis longus running here. Okay, so this tunnel which is formed beneath the flexor retinaculum is called as a tarsal tunnel. Guys, is called as a tarsal tunnel. Okay, now what happens is, in inflammatory conditions like diabetes or a hypothyroid state, or if it is in rheumatoid arthritis, when this tendon sheaths, okay, you can see the synovial sheaths, you can see all these synovial sheaths which are surrounding the tendon beautifully. When this synovial sheath gets inflamed, they compress the nerve which is running in the tunnel, and this nerve which is running in the tunnel is nothing but the tibial nerve, and this syndrome is called as tarsal tunnel syndrome. So what is called as tarsal tunnel syndrome? Compression of the tibial nerve, okay, in the tarsal tunnel. Compression of the tibial nerve in the tarsal tunnel is called as tarsal tunnel syndrome. Okay, it's called as tarsal tunnel syndrome. Okay, fine. So you have seen about lot of entrapment neuropathies. This is the last entrapment neuropathy we are seeing in the foot, close to the foot. Okay, so we are ready now. Fine. See, if you see this tarsal tunnel, so this tarsal tunnel syndrome, what is the nerve that is compressed in tarsal tunnel syndrome? Is a tibial nerve. So tibial nerve is the one which is getting compressed in the tarsal tunnel syndrome. Okay, so we have seen lot of entrapment neuropathies since yesterday. So if somebody asks you what is a nerve that is compressed in cubital tunnel, what you will tell? What is a nerve that is compressed in cubital tunnel? Yes guys, what is a nerve that gets compressed in the cubital tunnel? Okay, yesterday we saw that nerve. Okay, so the nerve that is compressed in cubital tunnel is, yes, it is nothing but the ulnar nerve. It is nothing but the ulnar nerve. So whenever there is an ulnar nerve, very good Muga and very good Anashwara. Okay, so whenever there is an cubital tunnel syndrome, you get ulnar nerve palsy, and whenever there is an tarsal tunnel syndrome, we get the tibial nerve palsy. Okay, so this is about the muscles of the posterior compartment of the leg. You can see the muscles of the posterior compartment of the leg. So it has got various groups in it, superficial and deep group. Okay, we'll just try to write down here. Okay, so the muscles of the posterior compartment, the muscles of the posterior compartment of the leg region. Okay, so we are classifying it into superficial group, and we are classifying into deep group. Okay, the superficial group has got 4 muscles. We have seen that one is called as gastrocnemius, 2 heads, gastrocnemius, 2 heads of gastrocnemius. Next comes the soleus, and next comes the plantaris muscle. Deep compartment, you got popliteus muscle, we got the tibialis posterior muscle, we have got the flexor hallucis longus muscle, flexor digitorum longus muscle. These are the muscles in the posterior compartment. You know all these muscles are supplied by the nerve supply for all these muscles. So the nerve supply for all these muscles are the tibial nerve. It is the tibial nerve which supplies all these muscles. Okay, we have seen about the action of these muscles. So these muscles causes plantar flexion of the ankle, they causes plantar flexion of the ankle, no doubt in it. What is the action of popliteus? Okay, what is the action of popliteus, guys? Okay, popliteus is an important muscle, okay, which causes unlocking of the knee joint, so unlocking of the knee joint is caused by popliteus, which is a very, very important question. Okay, yes Anashwara, in the diagram, yes, when you come to the cross sectional diagram, I have shown it in the different parts only. So this is the medial head of the gastrocnemius, and what you see here is the lateral head of gastrocnemius. Okay, so this is the lateral head, so this is the medial head of gastrocnemius, and this is the lateral head of gastrocnemius. I have shown it separately only. Okay, so I didn't show it as one, I have shown it separately, the medial head and lateral head I have shown it separately here. Okay, so there are 2 heads of gastrocnemius, that is what we are seeing here. Okay, so when you take these muscles, okay, so popliteus is a muscle which helps in unlocking of the knee joint. Okay, so this is an important muscle for unlocking of the knee joint. So when the joint goes in for flexion, initial flexion, it has to unlock, then only it can flex. So that unlocking of the knee joint is produced by popliteus muscle. Okay, I think we have seen well about the tibialis posterior muscle. What is the function of tibialis posterior muscle? That is a muscle which causes inversion of the foot. Flexor hallucis longus causes flexion of the great toe. Flexor digitorum longus causes flexion of the other toes. Okay sir, fine, very I think you are clear with this. I hope you are clear with this. Okay, so we have seen about the muscles of the posterior compartment of the leg, the muscles of the anterior compartment of the leg. Now coming to the muscles of the lateral compartment of the leg. Okay, coming to the muscles of the lateral compartment of the leg, we will go to the same cross section diagram. Now what is the surface which is free now? It is the lateral surface of the fibula which is free now. So in the lateral surface of the fibula you see 2 muscles. Okay, so the 2 muscles which are seen in this area are 2. One is peroneus brevis muscle, another one is called as peroneus longus muscle. Okay, so we'll just discuss about peroneus brevis muscle. Both of them arising from the fibula. Okay, I'll just write the muscles in the lateral compartment of the leg. Muscles of the lateral compartment of the leg. Okay, so there are 2 muscles in this group. One is called as a peroneus longus muscle. One is called as peroneus longus muscle. The next muscle is called as peroneus brevis muscle. Next muscle is called as peroneus brevis muscle. The peroneus longus muscle, though it arises from the fibula, it crosses all the way to the foot. It gets inserted into the, okay, where does peroneus longus gets inserted? It gets inserted into the base of, it gets inserted into the base of first metatarsal. It gets inserted into the base of first metatarsal, and also it gets inserted into the medial cuneiform bone. It gets inserted into the medial cuneiform bone. Okay, it gets inserted into the medial cuneiform bone. Okay, very very important. Base of first metatarsal and medial cuneiform bone. And peroneus brevis muscle, okay, it gets inserted, okay, peroneus brevis gets inserted into the base of the fifth metatarsal bone. Base of the fifth metatarsal bone is where the peroneus brevis gets inserted. Avulsion of the base of fifth metatarsal by the peroneus brevis. So avulsion of the peroneus brevis causes fracture of the base of the fifth metatarsal. And what is this fracture called as? Can anybody tell me what is the fracture of the base of the fifth metatarsal called as? Yes guys, it is due to the avulsion of the peroneus brevis muscle. Very good guys, very good. So that is called as Jones fracture. Very good guys, very good. So everybody, you are doing great guys. You are I think you are studying well. I hope in the next forthcoming NEET exams you are going to crack like anything, and hope we'll see you in all flying colors. So peroneus brevis is a muscle. When it gets avulsed from the base of the fifth metatarsal, it causes a fracture called as Jones fracture. Now both these muscles guys, peroneus longus and peroneus brevis, what does do? They do eversion of the foot. Okay, so what do they cause? They cause eversion of the foot. So I already told you, when you take the lateral border of the foot away from the ground, that is called as eversion of the foot. Both the peroneus muscles, both the peroneus longus and peroneus brevis muscle causes eversion of the foot. Okay, so this is about the lateral compartment of the leg muscles. Okay, so what is the nerve supply for these muscles? The lateral compartment of the leg is supplied by, okay, the lateral compartment of the leg is supplied by a nerve called as superficial peroneal nerve. Is supplied by a nerve called as superficial peroneal nerve. Okay, so both the muscles, both the peroneus longus and the peroneus brevis, are supplied by superficial peroneal nerve. Now where do the superficial peroneal nerve arises from? Where do the deep peroneal nerve arises from? Okay, so that there is a nerve called as common peroneal nerve. Okay, there is a nerve called as common peroneal nerve, and this common peroneal nerve divides into two branches. One is called as the superficial peroneal nerve. And the next branch is called as the deep peroneal nerve. The superficial peroneal nerve supplies the lateral compartment of the leg. Okay, so it supplies the two muscles, that is peroneus longus and peroneus brevis, which are basically the everters of the foot. Okay, and this superficial peroneal nerve continues as the cutaneous branch, and supplies the dorsum of the foot. Okay, so this superficial peroneal nerve is called as the musculocutaneous nerve of the leg. Okay, so superficial peroneal nerve is also called as what? The superficial peroneal nerve is also called as the musculocutaneous nerve of the leg. Okay guys, clear? So common peroneal nerve, it divides into two branches. Where it divides into two branches? At the neck of the fibula, it divides into two branches. You can see it in the picture. The common peroneal nerve winds around the neck of the fibula and divides into two branches. One is the superficial peroneal nerve to the lateral compartment, and another one to the deep peroneal nerve to the anterior compartment of the leg. So deep peroneal nerve supplies the anterior compartment of the leg. Okay, it supplies the anterior compartment of the leg. Remember guys, these compartment are the muscles which causes dorsiflexion of the foot. So they are the dorsiflexors of the foot, they causes dorsiflexion of the foot. Okay, and if they don't act, you know that it results in foot drop. Okay, and this deep peroneal nerve supplies the first web space, it supplies the skin of the first web space, it supplies the skin of the first web space. Okay guys, clear? So the deep peroneal nerve supplies the skin of the first web space. This is very important. Okay, this is supplied by skin of the first web space. Okay, so if you see the foot here, okay, so if you see the foot here, they have given the cutaneous innervation of the foot. Okay, so guys, please remember the entire foot on the dorsum is supplied by the superficial peroneal nerve. Okay, it is by the superficial peroneal nerve, it is by the superficial peroneal nerve. Okay, the first web space, you can see the first web space which is supplied by the deep peroneal nerve. Okay, deep fibular nerve is also called as deep peroneal nerve. Okay, the medial border of the foot, okay, the medial border of the foot up to the ball of the great toe is supplied by this nerve, that is the saphenous nerve. So saphenous nerve supplies the medial border of the foot. Okay, it supplies the medial border of the foot. Okay, and the lateral border of the foot is supplied by sural nerve. So the lateral border of the foot is supplied by sural nerve, lateral border of the foot is supplied by sural nerve. Okay, fine. So sometimes in the exams they ask dermatomal patterns, they ask dermatomal patterns. So what is called as a dermatome? Yes guys, anybody, what is called as a dermatome? The part of the skin, okay, the part of the skin which is supplied by a single spinal segment. Okay, the part of the skin which is supplied by a single spinal segment is called as dermatome guys, it is called as dermatome. So the dermatome on the medial border of the foot is L4, the dermatome of the first web space is L5, and the dermatome on the lateral border of the foot is S1. So these are the important dermatomes in the foot region, which is must know topic. Dermatome of the foot, what is mean by dermatome? Dermatome means, okay, what do you mean by dermatome guys? Yes, anybody? Dermatome means what? It is the part of the skin, it is a part of the skin supplied by, okay, it is a part of the skin which is supplied by single, okay, single spinal segment, it is supplied by single spinal segment, then that is called as dermatome. Similarly, you have got another term called as myotome, a muscle or a group of muscle which is supplied by a single spinal segment is called as myotome. So what we are seeing here is the dermatome of the lower limb, mainly the foot. So L4, L5 and S1 we have seen. Okay, so this is an important topic. Dermatome questions are frequently coming now. Okay, so if you want to add a few things in the dermatome, okay, so if you take the hand region, okay, so let us consider this is the arm, this is the forearm, okay, and let us consider this is the thumb region. Okay, this is the thumb, this is the index finger, this is the middle finger, this is the ring finger, and this is the little finger. Okay, fine. So if you see the deltoid region, if you see the deltoid region, okay, so you get a dermatomal pattern here, you get a dermatomal pattern here. So this area of the skin of the arm region, on the deltoid region and on the arm region, is supplied by C5. The outer border of the forearm up to the thumb is supplied by C6, the middle finger is supplied by C7, the little finger is supplied by C8, the inner border of the forearm, is supplied by T1, and the inner border of the axilla is supplied by T2. Okay, so this is the dermatomal pattern of the upper limb. Okay, so this is the dermatome of the upper limb guys, dermatome of the upper limb. Okay, so dermatome of the upper limb, over the deltoid region C5, over the thumb it is C6, over the middle finger it is C7, over the little finger it is C8, inner border of the arm it is T1, around the axillary region, it is T2. This is the dermatomal pattern of the upper limb dermatomal pattern are important when you want to know which spinal nerve is involved, okay, which spinal nerve is compressed. For example, if you have an intervertebral disc prolapse in the cervical region or in the lumbar region, it is a specific nerve root that is compressed. So if you want to identify the exact nerve root, you must check the correct dermatome and you must check the correct myotome. Then only you can able to identify then only you will be able to identify the correct level where the nerve is compressed. So that is why dermatomes and myotomes are useful here. Okay, so since we have seen about dermatome, just a few things about myotomes. Okay, so the myotome of the upper limb, C5 is for shoulder abductors. Okay, shoulder abductors are C5. C6, okay, is elbow flexors. Okay, C6 is elbow flexors. C7, okay, C7 is wrist flexors and the wrist flexors and the elbow extensors C8 is the finger flexors and T1 is the finger abductors Okay, what do you mean by all this? So myotome means it is a muscle or a group of muscle which supplies which is being supplied by a single spinal segment. Okay, see, for example, if I can able to flex my fingers, well, which means my C8 root is working well. If I able to fan out my fingers, which is finger abduction, my T1 root is working well. If I can able to flex my elbow, my C6 root is working well. So all these are dermatomes, all these are myotomes of the upper limb. Okay, so if you have the myotomes of the upper limb, what happens to the myotomes of the lower limb? So L3 is the myotome for knee extensors. If you ask the patient to extend the knee and check, you are checking the L3 myotome. L4 myotome is ankle dorsiflexors. L5 myotome is the great toe dorsiflexors. And S1 myotome is the ankle plantar flexors. Okay, fine guys. So these are all the myotomes of the upper and lower limbs. Okay, so please take down this very important topics. If you see the questions recently, they won't ask you this area is supplied by median nerve or ulnar nerve. No, they more specifically ask the myotome and the dermatomes. So these are all the myotomes and the dermatomes of the upper limb and the lower limb. Okay, fine. So L3 is for knee extension, L4 is for ankle dorsiflexion, L5 is for great toe dorsiflexion. Okay, L5 is for great toe dorsiflexion and S1 is for ankle plantar flexion. Okay, so if somebody asks you, okay, which is the dermatome which is used to check, that is used to check Babinski sign, which is the dermatome that is used to check Babinski sign? Can anybody tell me which is the dermatome that is used to check the Babinski sign, guys? Yes, anyone? So Babinski sign, which dermatome they are checking the Babinski sign, guys? They stroke the skin of the foot from the lateral side. Very good, Ashish. It is the S1. Dermatome which is being checked there. So that is the Babinski sign. Okay, so without wasting much of time, we'll go to the next part. Okay, so whenever there is a common peroneal nerve injury, so your dorsiflexors of the foot are not working. Okay, it falls down, so it causes foot drop. Okay, whenever there is a common peroneal nerve injury, whenever there is a deep peroneal nerve injury, also it results in foot drop. That is what they are showing in the picture here. So foot drop is happening because of the loss of foot dorsiflexion. Okay, when there is a common peroneal nerve injury, superficial peroneal nerve is also compromised. When the superficial peroneal nerve is also compromised, foot eversion cannot take place. Okay, so the foot automatically goes in for plantar flexion and inversion. Okay, the foot automatically goes in for plantar flexion and inversion, guys. Okay, so in and common peroneal nerve palsy. So in and common peroneal nerve palsy, okay, so there will be loss of foot, there will be loss of foot dorsiflexion. Okay, there will be loss of foot dorsiflexion and eversion. There will be loss of foot dorsiflexion and eversion. This is what happens in the common peroneal nerve palsy. This is what happens in the common peroneal nerve palsy. Okay, so we have done with the main sections of the lower limb. Okay, so we are just going to the blood supply of the lower limb now. Okay, so when you go to the blood supply of the lower limb, okay, so we'll see what are the important vessels which are seen here and what is their role here. So as you all know, the artery which comes to the thigh is a continuation of the external iliac artery. So what is this artery? This artery is called as external iliac artery. This external iliac artery continues as the femoral artery. This continues as the femoral artery. This continues as the femoral artery. The femoral artery, once it in the thigh, it gives lot of branches. We have seen about the branches in the morning. So this branch, what you see here, is called as a superficial. Is called as a superficial circumflex. It is a superficial circumflex iliac, okay, artery. It is a superficial circumflex iliac artery, and the artery what you see here is the superficial epigastric artery. It is a superficial epigastric artery. The artery which you see here is called as a superficial external pudendal artery. It's the superficial external pudendal artery. Okay, so these are all the superficial branches of the femoral artery in this area. This femoral artery also gives a deep branch, which is the artery of the thigh. We call this as the artery of the thigh. So this artery is called as a profunda. This is called as a profunda femoris artery. This is called as a profunda femoris artery. This is called as the profunda femoris artery, and this profunda femoris artery gives rise to two important branches for the proximal femur. Okay, if you see this branch is called as the lateral circumflex femoral artery. This is called as what? Lateral circumflex. This is called as lateral circumflex femoral artery. Okay, and you have got another branch which is running here. This is called as a medial circumflex femoral artery. This is called as medial circumflex femoral artery. Okay, so two important arteries for the proximal femur, guys, very important. They arise from the profunda femoris artery. So one is called as lateral circumflex femoral artery, another one is called as a medial circumflex femoral artery. They wind around the proximal femur and they supply the head of the femur. We'll see the head of the femur blood supply in a short while. So before that, you should know what are all the branches which are coming from the femoral artery. Okay, in the femoral artery also gives a deep branch here to the genital region, that is called as deep external pudendal artery. This is called as deep external pudendal artery. Okay, so once the femoral artery gives all these branches, then it continues down into the thigh region. It runs through a canal here. Yes, this canal is called as an adductor canal. Then it passes through an hiatus in the okay, you can see the hiatus here. It passes through the hiatus in the adductor magnus muscle. So this is called as adductor hiatus. Okay, this is called as adductor hiatus. And when it is running through the femoral canal, it gives the last branch here. The branch which arises from the femoral artery in the adductor canal is called as the descending genicular branch. It is called as a descending genicular branch, and this descending genicular branch, okay, gives rise to a branch called as the saphenous artery. This gives a branch called as the saphenous artery. So what is saphenous artery? Saphenous artery is a branch of what? Saphenous artery is a branch of the descending genicular artery. Saphenous artery is a branch of descending genicular artery. Okay, so that is the story of femoral artery. So it crosses from the inguinal region down to the adductor hiatus. It has got so many branches. Now where you will feel for the femoral artery pulsation in the inguinal region. Okay, so you will feel for the femoral artery pulsation, you will feel for the femoral artery pulsation, you will feel for the femoral artery pulsation at the mid inguinal point. Okay, just below half a centimeter below mid inguinal point. Okay, mid inguinal point, you feel for the pulsation of the femoral artery, you feel for the pulsation of the femoral artery. Suppose suddenly a child is coming to you. Okay, a child is coming to you. Okay, if you see the child's limb, one limb is shorter compared to the other limb. Okay, so I am just giving you a clinical scenario. Okay, a child is coming to you. Okay, if you see the child's limb, one limb is shorter compared to the other limb. Now you feel for the femoral artery pulsation in the hip region. Okay, on the shorter side the femoral artery pulsation is not palpable, okay, not palpable. Okay, this child has an history of fever. Okay, this child has an history of fever. Okay, and if the patient has got a scenario like this, what is your diagnosis? So the patient previously had an history of fever, followed which the patient had difficulty in walking, and when the patient presented to you, you can see one limb is shorter. Okay, when you feel for the femoral artery, it is not palpable. Very good, guys. This is septic arthritis of the hip. Okay, so septic arthritis of the hip in infant is called as Thom-Smith arthritis. It is called as Thom-Smith arthritis. It is called as what? Thom-Smith arthritis. When the femoral artery pulsation is not palpable, okay, that sign is called as, very good, Adira, very good. That is called as vascular sign of Narath. That is called as vascular sign of Narath. Okay, that is called as vascular sign of Narath, and this vascular sign of Narath is seen in number of conditions. So one such condition is developmental dysplasia of the hip. Okay, even in developmental dysplasia of the hip, when the hip gets dislocated, okay, you can see this vascular sign of Narath. Normally the femoral artery is palpable in the mid inguinal point. It is palpable in the mid inguinal point against the head of the femur. Once if the head of the femur is eroded or if it is dislocated, you cannot feel for the pulsation. When you cannot feel for the pulsation, that sign is called as vascular sign of Narath. That is not only seen in Thom-Smith arthritis, that can be seen in developmental dysplasia of the hip, that can be seen in dislocation of the hip in adults. So that sign is an important sign around this area which you should know. Okay, so after the femoral artery crosses through the adductor hiatus, it continues as the popliteal artery. Okay, it continues as the popliteal artery, and the popliteal artery and the other arteries in this region forms anastomosis around the knee joint, and the popliteal artery divides into two branches. Okay, one is called as an anterior tibial artery, and next is called as an posterior tibial artery. So what is happening to the popliteal artery? So femoral artery continues as popliteal artery. Popliteal artery in the leg divides into two branches. One is called as an anterior tibial artery, which goes to the anterior compartment of the leg, and it also gives rise to posterior tibial artery, which goes to the posterior compartment of the leg. Okay, and this artery also gives a branch which runs along the fibula, which is called as a peroneal artery. So this is the fate of the femoral artery. So how it divides? So femoral artery gives rise to popliteal artery gives rise to anterior tibial artery for the anterior compartment, posterior tibial artery for the posterior compartment. The posterior tibial artery also gives a branch to the lateral compartment of the leg, that is called as a peroneal artery. Okay, so this is about the lower limb blood supply. Very, very important topic, that is blood supply of the head of the femur. See, as you all know, the deep femoral artery, also called as the profunda femoris artery, gives rise to the lateral circumflex femoral artery. Okay, it gives rise to the lateral circumflex femoral artery, and medial circumflex femoral artery, which forms an arterial ring around the intertrochanteric region. They form an arterial ring around the intertrochanteric region, and from the arterial ring you get these arteries called as retinacular arteries. You get these arteries called as retinacular arteries. Okay, so you all know this, the blood supply to the head of the femur now comes through the retinacular arteries. Now if there is a fracture in this area, this retinacular arteries gets cut off and the femoral head loses its blood supply, and it results in a condition called as avascular necrosis of the femoral head. It results in a condition called as avascular necrosis of the femoral head. Okay, so it is because of the tear of the retinacular arteries the patient has avascular necrosis of the femoral head. Guys, please remember, you can ask me that there is an artery called as artery of ligamentum teres, which is a branch of obturator artery. Okay, so this is a branch of obturator artery which is coming here. What happens to that artery? So in an adult patient, okay, in an adult individual, this artery becomes very narrowed down. This becomes very thin. So the blood supply through this artery is very meager, so that cannot handle the blood supply of the head of the femur when the retinacular arteries are cut. So when the retinacular arteries are cut, it obviously in an elderly patient results in avascular necrosis of the femoral head. It results in avascular necrosis of the femoral head. Okay, so if there is a neck of femur fracture, okay, if there is a neck of femur fracture, obviously the patient will land up in this complication. Okay, so that is why neck of femur has to be treated, okay, properly. It has to be treated properly. There are a lot of treatment options for the head of neck of femur fracture. I am not going into the details of it. That will take another 2 days to discuss about all those things. So we'll just stop with this here. The retinacular arteries are the important arteries. Now the next question is, what is the artery which is mainly contributing to the retinacular arteries? What is the artery, okay, which is mainly contributing to the retinacular arteries? I know that retinacular arteries are the arteries which supplies the femoral head, but for the retinacular arteries, which is the main source, okay, main source of retinacular arteries arises from the medial circumflex femoral artery. So this is the important artery. This is an MCQ. This is an important artery for the head of femur. This is the important artery for the head of the femur, okay, because most of the retinacular arteries predominantly arises from the medial circumflex femoral artery. Okay, so that is the important artery for the head of the femur. Okay, that is the important artery for the head of the femur. Okay, fine. So if you see the arteries, okay, if you see the arteries of the lower limb, okay, so you can see they form number of anastomosis in the trochanteric region. One is called as trochanteric anastomosis and one is called as cruciate anastomosis. Okay, and so you see these anastomosis are formed between various blood vessels. Okay, so if you see the trochanteric anastomosis, okay, if you see the trochanteric anastomosis, it is formed, so it is like this, guys. Okay, so you got branches like this. Okay, so from the trochanteric anastomosis you got branches like this. So what are the branches which are contributing for the trochanteric anastomosis? One, so there is a branch from the superior gluteal artery, okay, branch from the superior gluteal artery, and a branch from the inferior gluteal artery contributes for the trochanteric anastomosis from above. The ascending branches, the ascending branches, okay, of the medial circumflex and the lateral circumflex femoral artery. Ascending branches of the lateral circumflex and the medial circumflex femoral artery forms the trochanteric anastomosis. Okay, forms a trochanteric anastomosis. Similarly, you got cruciate anastomosis and you got anastomosis around the knee malleolus. Okay, so all these anastomosis will help in collateral circulation. Okay, so when you see the foot, okay, okay, so you can see here it is the posterior view of the leg. You can see the posterior tibial artery. Okay, you can see the posterior tibial artery giving rise to the peroneal artery, and this posterior tibial artery continues into the foot, okay, as medial plantar artery and lateral plantar artery. It continues into the foot as medial plantar artery and the lateral plantar artery. Okay, so this artery is called as the lateral plantar artery. So this is called as the lateral plantar artery. Okay, lateral plantar artery and the medial plantar artery. Okay, so the lateral plantar artery and the medial plantar artery are the branches, or the two important branches, are the two important branches of the, okay, the lateral plantar artery and the medial plantar artery are the two terminal divisions of the posterior tibial artery, and the lateral plantar artery is the one which forms this arch. So that arch is called as plantar arch. So if somebody asks you what is the plantar arch, how it is formed, the plantar arch is an arterial arch present in the foot. It is formed mainly by the lateral plantar artery. Now can anybody tell me what is the artery that completes the plantar arch? So the artery which completes the plantar arch, okay, the artery which completes is a plantar arch, is an artery which runs on the dorsum of the foot, dips into the plantar aspect. Okay, so the artery which completes the plantar arch is nothing but the dorsalis pedis artery. It is called as the dorsalis pedis artery. It is called as dorsalis pedis artery. Very good, Vinita. It is dorsalis pedis artery. Okay, so in the foot, the tibial artery divides into medial plantar artery, lateral plantar artery, and the lateral plantar artery forms a plantar arch, and this plantar arch is completed by dorsalis pedis artery. Okay, I hope you remember yesterday in the upper limb session we were discussing about the ulnar arches, superficial ulnar arch and the deep ulnar arch. I think you know how the superficial ulnar arch is formed and deep ulnar arch is formed, and what are the main vessels which are contributing to those arches. Okay, to those arches. I hope you remember those things. Okay, fine. So the last thing what you see here in the picture is the course of the anterior tibial artery. Okay, you can see the anterior tibial artery runs in front of the interosseous membrane, Okay, when it runs in front of the interosseous membrane, it crosses the ankle. Okay, it gives the malleolar branches. So these are all the malleolar branches. Then the artery continues as the dorsalis pedis artery. Then this artery continues as the dorsalis pedis artery. Okay, and this dorsalis pedis artery gives rise to the medial and the lateral tarsal branches. Finally the dorsalis pedis artery goes and completes the plantar arch, and if you see from the plantar arch, okay, you can see the digital arteries. Coming from the plantar arch, supplying the digits. Okay, you can see from the plantar arch, you can see the digital branches supplying the digits. Okay, nothing much about it, so don't think too much about this arteries, not of much importance. So that is why I am not going into small steps by step here. So when you trace the anterior tibial artery gives rise to the following branches: malleolar branches around the ankle, then it continues as the dorsalis pedis artery, and this dorsalis pedis artery, you can see the tarsal branches, and you can see it ends in forming a plantar arch, Okay, so this finishes your the lower limb. Okay, last topic of the limb section, upper and lower limb combined together. The last section is the joints. We'll just do a crisp revision of the joints. We'll just see what are the types of joints, because it is a very important topic where question comes frequently. So we'll just see. So I would advise you to open a different page, okay, or take a separate paper or a note, okay, so that you can write down this, because I don't have space in the workbook there. So I will write the following. So the next half an hour class will be on this new page. Okay, so the joints of the limbs. Okay, so you can see the joints of the limbs. Now see the joints of the limbs. Before going into the joints of the limb, okay, you can classify the joints broadly into, okay, so you can classify the joints broadly into three types, guys. You can classify the joints. This is a general anatomy topic. You can classify the joints broadly into three types. One is called as an fibrous joint. Okay, so in fibrous joint, this is also called as synarthrosis. Synarthrosis means here no movements takes place. No movement takes place in this joint. Okay, the next joint, what you see here, okay, is the cartilaginous joint, where minimal movement can take place, so it is called as an amphiarthrosis. Then there is a joint which is called as the synovial joints, which is also called as diarthrosis, So you got basically three broad varieties of joints. Okay, I hope you know in the fibrous joint there is no movements, and the examples for fibrous joints are the sutures of the skull. Okay, sutures of the skull are an example for fibrous joint. The gomphosis, that is between the teeth and the teeth socket, it is an example for fibrous joint. Okay, syndesmosis, are an example for fibrous joint. Example for syndesmosis is inferior, okay, example for syndesmosis is inferior tibiofibular joint. Is an example for syndesmosis. Okay guys, so inferior tibiofibular joint is an example for syndesmosis. Also remember the middle radioulnar joint. Okay, middle radioulnar joint is an example for syndesmosis. Okay, so guys, please remember the cartilaginous joints and the fibrous joint and the synovial joints. Lot of questions comes from this topic. So what is fibrous joint? Fibrous joint is a joint where movements doesn't takes place much. It is called a synarthrosis. Examples sutures of the skull, namely the sagittal sutures, the coronal sutures, okay, the lambdoid sutures. Okay, all these are examples for sutural joints. Gomphosis between the teeth and the socket is called as gomphosis. Syndesmosis is a fibrous joint where no movement takes place. These are all most frequently asked questions. Okay, many times these questions have come. Also, please have an understanding of this. Now, cartilaginous joint. Okay, what is called as a cartilaginous joint? Okay, so there are two types of cartilaginous joint. One is called as a primary cartilaginous joint. Another one is called as a secondary cartilaginous joint. One is called as a primary cartilaginous joint. Another one is called as a secondary cartilaginous joint. Now, what is this primary cartilaginous joint and secondary cartilaginous means? If there are two bones like this, you take two bones like this, and you connect these two bones by means of an hyaline cartilage. Okay, I take two bones and I connect these two bones by an hyaline cartilage. If I connect these bones by an hyaline cartilage alone, these are called as primary cartilaginous joint. Okay, so example for primary cartilaginous joint are one is first chondrosternal joint. The first chondrosternal joint is an example for primary cartilaginous joint. Okay, the metaphyseal region and the epiphyseal region are joined by a plate called as physeal plate. Physeal plate is an area which is called as an primary cartilaginous joint. This primary cartilaginous joint is also called as synchondrosis. It is called as synchondrosis because syn means union, chondrosis means cartilage. Two bones are united only by an hyaline cartilage. This is called as synchondrosis. Very, very important. This is one of the frequent question which was asked. First chondrosternal joint is an example for synchondrosis. Now, what is called as a secondary cartilaginous joint? Secondary cartilaginous joint are also called as symphysis. They lie usually in the midline of the body. Okay, so where do they lie? They lie in the midline of the body. If you see some joints in the midline, usually that will be symphysis kind of joint. What is called as and symphysis or an secondary cartilaginous joint? You take two bones. Okay, you line the two bones with a cartilage. So this cartilage which is lining here is the hyaline cartilage, and they are in turn connected by an fibrocartilage. Okay, they are in turn connected by an fibrocartilage. So what is this? So we have got only hyaline cartilage here. But here you have got hyaline cartilage and you got fibrocartilage also. So when you got two cartilages here this kind of joint is called as an symphysis joint or an secondary cartilaginous joint. Guys, please remember this joint usually lies in the midline of the body. Example is pubic symphysis. Example is pubic symphysis. Okay, example is pubic symphysis. The joints present between the vertebrae, okay, that is the intervertebral joints, that is the intervertebral disc. Okay, the intervertebral disc forms the symphysis kind of, or the secondary cartilaginous type of joint, forms the symphysis or the secondary cartilaginous type of joints. Okay, so these are certain examples for the cartilaginous joint. Next comes the synovial joints. Okay, I hope you know what is called as a synovial joint. Okay, synovial joint means this will have the following features. Okay, so usually if you take a joint, okay, synovial joints, okay, let us consider this is a bone, this is another bone which are forming the joint here, Now if it is a synovial joint, this synovial joint will be covered on its outer aspect, by a capsule. So usually the synovial joints will have a capsule, so they will have a capsule, and inside the capsule, okay, the synovial joint is lined by, okay, it is lined by a membrane. This membrane is called as a synovial membrane. Okay, so this membrane is called as what? This membrane is called as a synovial membrane. And this synovial membrane, what does it do? This synovial membrane will secrete fluid within the joint. It will secrete fluid within the joint, and the fluid which is secreted within the joint is called as a synovial fluid. So what is this fluid called as? This fluid is called as a synovial fluid. This fluid is called as a synovial fluid. Okay, fine. So when you take an synovial joint, so it will have a capsule, it will have a synovial membrane, and that synovial membrane will produce fluid within it. It is called as a synovial fluid. Now if you see the articulating surfaces, of the synovial joints are covered by a cartilage. This cartilage is called as an articular cartilage. So what is this cartilage called as? This cartilages are called as the articular cartilage. Okay, these are called as the articular cartilages. Now what is the importance of articular cartilage? The articular cartilage is devoid of perichondrium. It is devoid of perichondrium. Okay, it is devoid of perichondrium. So articular cartilages are devoid of perichondrium. Okay, when it is devoid of perichondrium, it cannot regenerate. Okay, so that is why when an articular cartilage is damaged, the joint will be totally lost. It will be totally functionless. It will become functionless if the articular cartilage is destroyed, because articular cartilage is devoid of perichondrium. When it is devoid of perichondrium, the cartilage cannot regenerate. Okay, it cannot regenerate. Fine. So based on various types of the articulating surfaces, the synovial joints are classified into various types like ball and socket joint. Okay, based on the type of articulating surfaces, it is called as a ball and socket joint, or it is called as a saddle joint. Okay, we will see examples for all this when we come to the each individual joints. So this is called as a ball and socket joint, saddle joint, and you can have joints like pivot joint. Okay, you can have joints like pivot joint. Okay, you can have joints like condylar joints. So based on the type of the articulating surfaces, they are called as by various names. Okay, and based on their axis in which the synovial joints move. If the joint moves in only one axis, it is called as an uniaxial joint. Can anybody tell me an example for an uniaxial joint, guys? It moves in only one direction. Yes. Hinge joint is a type. Yes. Elbow joint, very good. Elbow joint and the interphalangeal joints of the fingers are examples for uniaxial joint. Okay, can anybody tell me an example for an biaxial joint, guys? Biaxial joint. Okay, biaxial joint, example is wrist joint. Is an example for biaxial joint. Example is biaxial joint is this joint. Multi-axial joint or an polyaxial joint. Multi-axial joint or an polyaxial joint. What is the nerve or what is the joint that moves in different directions in multiple directions? They are called as multi-axial joint. Example is shoulder joint. Example is shoulder joint. It moves in multiple direction. Okay, example is shoulder joint. Example is hip joint. They are all examples for multi or polyaxial joints. They are all examples for multi or polyaxial joints. Okay, so these are all various examples or various types of the synovial joints. Okay, so keeping this introduction by the side, okay, we'll just see the individual joints. We will not go into the depth of the joints because it will make the topic very wide and vast. We'll just see the name of the joints, we'll just see the ligaments in the joints and the actions around the joint. Okay, so first joint is the shoulder joint. I'm discussing only the important joint, guys. Okay, so first joint will be the shoulder joint. First joint is the shoulder joint. Okay, you all know that shoulder joint is a ball and socket joint. It is a ball and socket joint. Okay, it is a ball and socket joint. It is a polyaxial joint. It is a polyaxial joint and it is a simple joint. Only two bones articulates here. So only two bones articulates here. It is called as a simple joint. So if you see the articulating surfaces, so this is the head of the femur, sorry, head of the humerus. So this is the head of the humerus. Okay, and the head of the humerus articulates with the glenoid cavity. So these are the articulating surfaces. So what are the articulating surfaces here? Okay, the articulating surfaces are, okay, the articulating surfaces are, one is the head of the humerus, one is the head of the humerus, and another one is the yes guys, another one is the glenoid cavity. These are the articulating surfaces. These are the articulating surfaces. Okay, these are the articulating surfaces. Now the shoulder joint, is you all know, it is a weak joint. It is a weak joint. Okay, so this weak joint is stabilized by means of number of structures. So you know that there are certain conditions or there are certain structures called as stabilizers of the shoulder joint. Stabilizers of the shoulder joint. Okay, what are the stabilizers of the shoulder joint? There are two kinds of stabilizers. There are two kinds of stabilizers. One is called as static stabilizers. One is called as static stabilizers, and then one is called as dynamic stabilizers. Then is called as dynamic stabilizers. Okay, so when you take the static stabilizers are usually the capsule. Okay, the static stabilizers are usually the glenoidal labrum. Okay, so these are all the static stabilizers. Okay, the capsule, the glenoidal labrum, and the ligaments. And what are all the ligaments which are present here? The ligaments which are present here are the glenohumeral ligaments. Glenohumeral ligaments. There are three glenohumeral ligaments: superior, middle, and inferior glenohumeral ligaments. Okay, so that is a ligament which extends between the joint cavity from the glenoid to the humerus bone. It is nothing but the thickening of the capsules. These ligaments are called as glenohumeral ligament. There are three: superior, middle, and inferior glenohumeral ligaments. Okay, fine. So dynamic stabilizers are the rotator cuff muscles. So rotator cuff muscles are the one which forms a dynamic stabilization, which gives dynamic stabilization. So these are all the structures which stabilizes the shoulder joint. Okay, these are the structures which stabilizes the shoulder joint. As you all know, since this is the synovial joint, you will have the capsule which is surrounding the shoulder joint. You will have the capsule which is surrounding the shoulder joint. Okay, and this capsule gets thickened in three places. Okay, so this is 1, this is 2, and this is 3. So it gets thickened in three places. These thickenings are called as the glenohumeral ligament. So this is called a superior glenohumeral ligament. This is called as a middle glenohumeral ligament, and this is called as the inferior glenohumeral ligament. This is called as the inferior glenohumeral ligament. Okay, so that is about the ligaments. There are other ligaments here. Okay, one is called as an coracohumeral ligament. One is called as an coracohumeral ligament, and there is another ligament which is seen in this area, that is called as an transverse humeral ligament. That is called as a transverse humeral ligament. All these are ligaments which are seen around the shoulder joint. Now shoulder joint is an multi-axial joint? Yes, it moves in several directions. So what are the actions of the shoulder joint? Okay, the actions of the shoulder joint are following. One is the flexion. Okay, one is the flexion. I am going to highlight only the important muscles. I am not going into the minor actions of the muscles. The important flexor is pectoralis major. Is pectoralis major muscle. Okay, it is pectoralis major muscle. And the extension of the shoulder joint. Extension of the shoulder joint is produced by the latissimus dorsi muscle. It is produced by the latissimus dorsi muscle. It is produced by the latissimus dorsi muscle. Okay, and adduction or the abduction of the shoulder joint. Abduction of the shoulder joint is produced by three group of muscles from 0 to 15 degree. It is by supraspinatus. It is by supraspinatus, guys. So from 0 to 15 degree, initiation of abduction, initiation of shoulder abduction from 0 to 15 degree is only by supraspinatus. From 15 to 90 degree is by deltoid muscle, and 90 to 180 degree is by, along with this muscles, serratus anterior muscle plus trapezius helps in it. Serratus anterior muscle and trapezius helps in it. So this is a very important topic. Next comes the adduction of the shoulder joint. Adduction of the shoulder joint is again produced by pectoralis major. It is again produced by pectoralis major. It is also produced by teres major. Okay, it is also produced by teres major. It is also produced by teres major. Medial rotation of the shoulder joint is again produced by pectoralis major. It is again produced by pectoralis major. It is produced by latissimus dorsi and is also produced by teres major. Okay, what is called as a medial rotation? If you keep your limb like this and if you take the palm towards your body, that is called as medial rotation. That is called as what? Medial rotation. So this is called as a medial rotation and this is called as lateral rotation. This is called as lateral rotation. Okay, so lateral rotator of the shoulder joint are, so the lateral rotators are mainly the, okay, the lateral rotators are mainly the infraspinatus and the teres minor muscle Okay, fine, guys. So the action of the muscles around the shoulder joint. So shoulder joint does in multiple actions. Okay, it moves in multiple axes. So you can see the muscles which are participating in it. I am just highlighted only the important muscles here. Okay, and if the shoulder joint goes in for pathology, okay, so what happens is it can go in for various kinds of pathology. Most common pathology is shoulder dislocation. Okay, the most common type of shoulder dislocation is anterior shoulder dislocation. Anterior shoulder dislocation is the most common type. Anterior shoulder dislocation is the most common type. Okay, I am not going into the details of the shoulder dislocation. Anterior shoulder dislocation is the most common type of shoulder dislocation. The other types of shoulder dislocation are posterior and inferior shoulder dislocation. Okay, now when the capsule of the shoulder joint becomes tight, then this condition is called as frozen shoulder. This condition is called as frozen shoulder, and this is also called as periarthritis of the shoulder. Commonly seen in diabetes mellitus. It is mainly the middle glenohumeral ligament which becomes tight. Okay, so it is mainly the middle glenohumeral ligament which becomes tight. Okay, sometimes the inflammation of the supraspinatus. Okay, so inflammation of the supraspinatus can happen, okay, in the players usually. So that is called a supraspinatus tendinitis. So when the patient has got supraspinatus tendinitis, when he do abduction of the shoulder joint, he will have pain between 90 degree to 120 degree, which is called as painful arc syndrome. This is called as a painful arc syndrome. Okay, because at this arc the supraspinatus tendon gets rubbed with the acromion. So when you lift your limb like this between 90 to 120 degree, the acromion will rub with the supraspinatus tendon, causing severe pain, that is called as painful arc syndrome. So these are certain pathologies around the shoulder joint. Okay, these are certain pathologies around the shoulder joint. Next comes the elbow joint. Okay, next comes the elbow joint. So elbow joint, as you all know, the elbow joint is an uniaxial joint. It is an uniaxial joint. Okay, it is a compound joint. Okay, it is a compound joint. It is a compound joint because more than two bones articulates in it. And what are the bones that articulate in the elbow joint? Okay, so the articulating surfaces are one is the distal humerus. Okay, and next is the ulna, and next is the proximal radius. So these are the three bones which articulates with the elbow joint. Okay, so when you see the elbow joint, okay, this is a synovial joint, so free movements takes place here, and I'm just drawing a lateral view of the elbow joint to see the ligaments. So this is the distal humerus. This is a distal humerus. Okay, so this is the olecranon process, and this is the coronoid process of the ulna. So this is the olecranon process and the coronoid process of ulna. So what is this? This is the humerus bone. And what is this process called as? This is called as the olecranon process. And what is this process called as? This is called as the coronoid process. So if I see the ulna bone, what is this view is called as? This view is called as the medial view of the elbow joint. This is called as a medial view of the elbow joint. Now on the medial side you get a ligament which is called as the medial collateral ligament or the ulnar collateral ligament. So you get a ligament here. So this ligament is ligament which has got three bands. Okay, it has got three bands here. Okay, so what is this ligament? This ligament is called as what? This ligament is called as the medial collateral ligament. This is called as a medial collateral ligament. Okay, this is called as a medial collateral ligament. It has got three bands. It has got an anterior band, it has got an posterior band, it has got an oblique band. Don't worry about it. There is a band which is seen here. This is called as medial collateral ligament. The take home message is one important nerve runs close to this band. The nerve which runs close to this is anybody? What is the nerve that runs on the medial side of the elbow joint? Okay, running close to the medial collateral ligament, that is ulnar nerve. Excellent guys, that is ulnar nerve. So this is ulnar nerve. Excellent guys, excellent Inya and excellent Vinita, everybody, very good. So this is about the medial collateral ligament. Now when you see the humerus from the lateral side, okay, again we'll draw a simple diagram guys. So this is the distal humerus capitulum, and this is the distal humerus what you see here, and this distal humerus on the lateral side, it articulates with the radius bone. Okay, and you know that this is called as the head of the radius. And this head of the radius is surrounded by a ligament which is called as what? This is called as an annular ligament. Okay, this is called as an annular ligament. So what is this ligament which is surrounding the head of the radius called as? So this is called as an annular ligament. And there is a ligament which arises from the lateral epicondyle getting attached to this annular ligament, and this ligament what you see here is called as the lateral collateral ligament. So this is called as the lateral or the radial collateral ligament. Okay, it's called as a lateral or the radial collateral ligament. So where it is attached? Proximally it is attached to the lateral epicondyle, distally is attached to the annular ligament. So these are the two important ligaments here. Okay, so elbow has got only two set of movements. One is flexion, another one is extension. Okay, one is flexion, another one is extension. Flexion I think you know what is the muscle which causes flexion here. So the muscle which causes flexion of the elbow joint are brachialis and brachioradialis, okay, and the biceps brachii and the biceps brachii. Extension is caused by two muscles. One is called as triceps and another one is called as anconeus. Okay, so one is called as the triceps, another one is called as anconeus. So these are the two movements which takes place at the elbow: flexion of the elbow and extension of the elbow. These are the muscles which causes the flexion and extension, which causes the flexion and extension, which causes flexion and extension. Okay, so this is about the elbow joint. And elbow joint, again, it can dislocate. So the possibility of elbow joint is it can dislocate. The most common dislocation is again posterior dislocation here. Elbow joint, most common type of dislocation is posterior dislocation, is most common type, okay, is most common type. So remember about this. And remember, when there is an elbow dislocation, most common nerve is injured is ulnar nerve. Shoulder joint dislocation, most common nerve injured is axillary nerve, is axillary nerve. Okay, so this is about the elbow joint. Next is there are several other joints. We'll just see the types of the joints. Okay, so that is more than enough. So one is called a sternoclavicular joint. Okay, sternoclavicular joint. This sternoclavicular joint is an complex joint, because it has got an intra-articular disc. It has got an intra-articular disc, and it is a saddle type of joint. Okay, the next joint in the shoulder region is acromioclavicular joint. Acromioclavicular joint is a type of plain synovial joint. It is a type of plain synovial joint. This is also a complex joint because it has got an articular disc within it. So this is a complex joint. Okay, only one thing about in acromioclavicular joint, there is an important ligament here called as coracoclavicular ligament. There is an important ligament related to the acromioclavicular joint, that is called as coracoclavicular ligament. It is one of the strongest ligament in the body. It is like the iliofemoral ligament in the lower limb. Okay, this is one of the strongest ligament in the body. So acromioclavicular joint, so don't forget about coracoclavicular ligament. Okay, then if you see the proximal radioulnar joint. Okay, proximal radioulnar joint. So the proximal radioulnar joint is an example for pivot joint. Pivot joint. Proximal radioulnar joint is an example for pivot joint. Okay, and whenever there is an proximal ulnar fracture, with proximal radioulnar joint dislocation. Okay, whenever there is a proximal ulnar fracture with the proximal radioulnar joint dislocation, this kind of injury is called as what? Can anybody tell me what is the injury where you got a proximal ulnar fracture with an proximal radioulnar joint dislocation? Very good Hari, Anashwara, very good Hari, very good Prithviraj. It is called as Monteggia fracture dislocation. Okay, so the next joint which you see here is the middle radioulnar joint. This middle radioulnar joint is an syndesmotic type of joint. Okay, there is a joint called as inferior radioulnar joint. This inferior radioulnar joint is an example for pivot joint. Okay, it is an example for pivot joint. Okay, so sometimes what happens is in the younger age, less than 6 years of age, if you take the child holding the forearm, okay, this proximal radioulnar joint can dislocate. So proximal radioulnar joint dislocation in an younger child is called as pulled elbow. It is called as what? Pulled elbow. It is also called as nurse made elbow. It is also called as what? Nurse made elbow. Okay, it is also called as nursemaid elbow. Fine. So this is about the radial ulnar joint. The next joint is the wrist joint. Okay, the wrist joint is an ellipsoid joint. Okay, it's an ellipsoid joint. Okay, it is an ellipsoid joint. In lot of movements takes place in the wrist: flexion, extension, and abduction, adduction. Lot of movements takes place in this. I hope you have discussed about those actions yesterday itself. So wrist joint is an example for ellipsoid joint. Okay, and one important thing in wrist joint is, okay, please remember, ulna does not participate in wrist joint. Ulna does not participate in the wrist joint. That is why wrist joint is also called as a radiocarpal joint. It is not called as radio ulnar carpal joint. It is called as a radiocarpal joint because ulna does not participate in the joint. Why? If you see the distal radius, and if you see the distal ulna, so the joint between the proximal row of carpal bones and the radius is called as the radiocarpal joint. So this is the wrist joint. Now you can ask me, sir, you can see the ulna which is coming in contact with the carpal bones? No. So there is an important structure which prevents the ulna from contacting with the wrist joint. So this structure what you see here is called as an articular disc, and they form a complex called as, okay, so this is the articular disc. This is an articular disc. They form a complex called as triangular fibrocartilaginous complex. They form a complex called as TFCC complex. So ulna does not participate in the wrist joint. That is why this joint is called as a radiocarpal joint. This joint is called as radiocarpal joint. Okay, so the next joint which is very important is the first carpo-metacarpal joint. And this first carpo-metacarpal joint is an example for a saddle joint. Again, is an example for a saddle joint. Okay, it is an example for a saddle joint. It is found between the trapezium and the base of the first metacarpal. Okay, it is an example for saddle joint. Okay, the next joint is the interphalangeal joints. Okay, and these interphalangeal joints are example for condylar joints. They are example for condylar joint, and they are also example for hinge joint. Okay, they are strict uniaxial joints. They are example for hinge joints. Okay, so these are all the main joints in the upper limbs. Okay, so to conclude the joints, we will just say hello to the hip joint. Okay, so hip joint, you all know, it is again stable joint. Okay, it is formed between the acetabulum. And it is found between the head of the femur and the head of the femur. Okay, so these are the two articulating surfaces here. Okay, so if you see the hip joint, okay, it has got various ligaments in it. The ligament of the hip joint are, one is the acetabular labrum. Okay, one is called as acetabular labrum. Okay, very important, acetabular labrum. Okay, it also forms certain ligaments here. This is called as an iliofemoral ligament. Is also called as ligament of Bigelow. Okay, it is also called as ligament of Bigelow. This is the strongest ligament in the body. Okay, very important, guys. It is the strongest ligament in the body, and this is the ligament which helps in preventing the hyperextension of your body. Okay, when it prevents you from falling backwards. So this is the ligament which prevents the hyperextension. It prevents the hyperextension of the hip joint. Okay, it prevents the hyperextension of the hip joint. The next ligament which you see here is the pubofemoral ligament. And ischiofemoral ligament. Okay, so these are the ligaments which are seen in this hip joint. Okay, there is also a small ligament which is called as TAL, which is called as transverse acetabular ligament. Okay, transverse acetabular ligament, and ligament of head of the femur. head of the femur are all the ligaments which are seen around the hip joint. So these are all the ligaments which are seen around the hip joint. Okay, hip joint, as you all know, it is an multi-axial joint, so multiple movements takes place. So the actions of the hip joint are, or the movements of the hip joint are: one is flexion. Again I am writing only the important muscles. The flexor of the hip joint is iliopsoas, very important. It is a strong flexor of the hip joint. Iliopsoas is the strong flexor of the hip joint. So if you are going to flex your hip, it is due to iliopsoas, strong flexor of the hip joint. Extension or the extensor of the hip joint is the gluteus maximus, the abductor of the hip. The abductor of the hip are the two main muscles, gluteus medius and gluteus minimus. We have seen this. Okay, their action loss will result in Trendelenburg test. Okay, yes guys, it results in Trendelenburg test. Okay, so then there is an another muscle which causes adduction of the hip joint. So those are the adductors, that is the adductor longus, adductor brevis and adductor magnus. So they are the adduction muscles, so they causes adduction of the hip joint. The medial rotators. Okay, so the medial rotators are the gluteus medius and minimus again, which causes the medial rotation of the hip joint, and the lateral rotators of the hip joint. The lateral rotators of the hip joint are the piriformis mainly, and the short external rotators, that is the gemellus and the quadratus femoris muscle. They are the short external rotators. Okay, so these are all the action of or the movements which takes place at the hip joint. So flexion is by iliopsoas, extension is by gluteus maximus, we have seen that. Abduction is by gluteus medius and minimus, adduction is by adductor longus, brevis and magnus. Medial rotation is by gluteus medius and minimus, and lateral rotation is by piriformis and short external rotators. I hope you are clear with the action and the things related to hip joint. So hip joint can also dislocate. Okay, dislocation also happens in hip joint. Posterior dislocation is common. Here. This is the most common type, guys. When posterior dislocation happens, it can cause injury to sciatic nerve. Okay, these injuries are called as dashboard injuries. These injuries are called as what? Dashboard injuries. Okay, these injuries are called as dashboard injuries. Okay, so this is about the hip joint. Okay, we have discussed about the knee joint. Okay, and last is the ankle joint. Okay, so just if you see the ankle joint here in the workbook, they have given a picture. We will just complete that picture so that you will be satisfied with the things what you have done. So here there are two things related to the ankle joint. So the ankle joint is covered on the medial side by the deltoid ligament, and on the lateral side by the lateral collateral ligament. Okay, okay, so this deltoid ligament has got two parts in it. Okay, so deltoid ligament is around the ankle joint, where it is seen on the medial side. And it has got two components in it. One is called as a superficial component, another one is called as a deep component. Another one is called as a deep component. And what is the superficial component? The superficial component is what you see here. This is the first part. This is one, and the one is represents a tibio-navicular part. And the two represents okay, the two represents a tibio-calcaneal part. And the three represents, okay, so this is the three, and the three represents, okay, so this is 2, and we'll just erase this. Yes, so this is 2, and the 3 represents, okay, 3 represents the posterior tibio-talar part. And what is the deep part? Deep part is the anterior tibio-talar part. Anterior tibio-talar part is the deep part. So that is the fourth one which you see here. It is the fourth one which you see here. So if you see this four components, these four components join to form the deltoid ligament. They form the deltoid ligament. They support the joint on the medial side. They support the joint on the medial side. Okay, on the lateral side, if you see, you got the lateral collateral ligament. You got the lateral collateral ligament. Okay, on the lateral side. Okay, and this lateral collateral ligament has got three components. Okay, this is 1, this is 2, and this is 3. Okay, so what are those? 1 represents the anterior talofibular ligament, 2 represents the calcaneofibular ligament, and the 3 represents the posterior talofibular ligament, and this is the anterior talofibular ligament, which goes in for, okay, commonly it goes in for, okay, commonly it gets injured. It is the injured ligament in the ankle. It is the one which is commonly gets injured, especially in an inversion type of injury, So that is what they was. Ligament most commonly affected in inversion sprain is nothing but the anterior talofibular ligament. It is the anterior talofibular ligament is the one which gets commonly injured in this. Okay, so this ligament is the ligament which is surrounding the ankle joint. So you also know that there is a joint below the ankle which is again an important joint called as a subtalar joint. Okay, it's called as a subtalar joint. Okay, subtalar joint is formed between the talus and the calcaneum. The main action which takes place in the subtalar joint are the inversion and the eversion. Okay, so normally when you do an inversion of the foot or eversion of the foot, there are lot of movements takes place at the other joints also. So the entire foot moves as a unit. So the movement which actually takes place together is called as supination. So in supination you got plantar flexion at the ankle joint. Okay, you get inversion at the subtalar joint, and you get adduction of the foot at the transverse dorsal joint, Okay, so these three movements takes place in supination. So supination of the foot involves 3 movements. Okay, if you try to do inversion, okay, just you try in your legs. When you try to do inversion, your ankle will automatically go in for plantar flexion, your subtalar joint goes in for inversion, and your transverse dorsal joint will go in for adduction. Similarly, when you do an eversion, okay, so that is called as pronation of the foot, where the ankle goes in for dorsiflexion. Okay, the subtalar joint goes in for eversion, and the midfoot or the transverse dorsal joint goes in for abduction. Okay, so these are the actions which takes place in the foot. So usually foot moves as a single unit. So this is how the actions takes place here. So supination and pronation, you should know what are the adjoint movements and what are all the joints where this movements takes place. Okay, so this is about the various joints of the upper limb and the lower limb. I think we have touched almost most of the areas of the limbs. Maybe one or two areas if it is left, I think you can study in future. If you have any classes, we will try to cover it up. So we will take a short break now, and when we come back after the break, okay, we will try to start the abdomen. Okay, we will start the abdomen after the break. Okay.